Good morning and welcome to Medical Grand Rounds. So wonderful to see so many familiar faces out there. Just as a reminder, next week's talk will be the annual Goldman Berland Lectureship, and we'll be hosting Dr. Doug White from the University of Pittsburgh. He'll be giving the talk, How to Make Sense of It All, Prognosis and Surrogate Decision Making in the ICU. So please join us next week as well. Today, I'm delighted to introduce Dr. Joseph Whetstone. Interestingly, he himself did his medical school training at University of Pittsburgh as well. Then went on to do diagnostic radiology residency and served as chief resident at OHSU. Dr. Whetstone then went into practice in general radiology, serving community hospitals in the Columbia River Gorge before returning to OHSU to complete further fellowship training in cardiothoracic radiology. He has several peer-reviewed publications. He's presented extensively on case reports, his research, radiology topics. We're really delighted to have him here at St. Vincent's since 2017 to bring his particular expertise and to teach us about that today. So thank you, Dr. Whetstone.
Good morning, everybody. Thanks for having me. Can everybody hear me okay? Dim the lights a little bit. Hopefully nobody will fall asleep. So no financial disclosures. Obviously, this is an imaging talk, so there's an inherent bias in that my career is entirely about imaging. Just to go through kind of the things we're going to be talking about, because this is sort of a mixed group of different specialties and subspecialists and primary care, I wanted to do a little bit of a review of kind of basic CT and MRI to kind of get everybody a little bit to the same level here. We talk about kind of current applications that we do for cardiac CT imaging. And then once we have sort of a foundation, we can go into more of like the evidence behind applying calcium scoring and coronary CT angiography to clinical practice. After that, we can get into sort of technologies that are in the pipeline and in the next probably 5 years we'll see more and more of. The second part of the lecture, because CT and MR are kind of two different topics, I thought I would separate them, but the second part we're going to talk about cardiac MRI and kind of our use of cardiac MRI in our current practice, and then kind of very exciting for me in that the hospital is buying a new or updating an MRI, so within not too long we're going to have a new machine that will allow us to do kind of more quantitative analysis of a lot of cardiac things. So that'll be in the next year or so. But I thought I would introduce the group to what's available coming out. So I've been to a lot of MRI or radiology and MRI talks where slides like this get shown, and there's sort of a word salad of different imaging sequences, and the room's dark, it's early, I don't want to put anyone to sleep, so we're not going to talk about that. I tried to put a lot of images and give some examples to keep everybody awake. Just as a warning, this isn't a real eyesore of a chart, so I am going to show this. And there's one unavoidable use of the term T1 later on, but you've all been warned. So hopefully I'll keep your attention through those. So starting out with CT, just as an introduction, this is a standard CT axial contrast enhanced image through the chest, kind of at the level of the aortic root. This is not good for cardiac imaging because there's relatively poor temporal resolution. So you can see with the with the red arrows here, this is where the RCA should be, but there's just a blur. We've got kind of the LAD and left main here. Can't make anything out there. And there's kind of a duplication of the RCA. With these blue lines or blue arrows here, you get this typical kind of duplication artifact of the aortic root because the heart's beating while you're scanning. So this is sort of historical, conventional CT that isn't great for cardiac imaging. It's more of a sort of great for the lungs, soft tissues, bones, but you can't tell much about the heart. So to get around this should be familiar. Kind of the CT trick we do is called cardiac gating. So there are a couple ways to do it. You can either turn the CT on for only parts of the cardiac cycle over one or several beats. This is called prospective gating. So you only get images at certain points, and then you can kind of summarize those to freeze cardiac motion. Or you can do retrospective gating, where it's kind of the equivalent of like holding the camera button down on your iPhone and taking a burst of pictures and then afterwards you can kind of have the computer reconstruct things to the phase of cardiac cycles. So these are kind of the difference of this. So on the left side, the radiology right, is the standard CT image with all the motion artifact. And here's an EKG-gated CT. So in comparison, you can see the RCA ostium and proximal portion. You see that the aortic root wall has a clearly defined margin to it. So there's not the same motion artifact. We've got the circumflex down here that looks nice. So when we apply cardiac gating techniques, then we can start to better assess the heart, the cardiac function, coronary arteries, and do a bunch of other applications. So once we have that image, we can do kind of more complex manipulation where we do three-dimensional or multiplanar reconstructions that will help us out. So I apologize to the radiologists in the back because this is going to be sort of a run-through of things that we already know, but kind of general topics of current applications, and then towards the end we can get into some of the evidence behind it. So one of the main things is coronary anatomy. So this is a great anatomical study. So whether it's for surgical planning or assessing congenital heart disease with structural abnormalities, CT is a great way to do that. Sometimes we have patients with young patients with chest pain, suspected anomalous coronary arteries, or maybe a failed catheterization where we can't find the ostium. But this is a young patient where the left coronary artery rises from a common cusp with or from the right coronary cusp with the common origin of the RCA. We can do these kind of three-dimensional modelings that can sometimes help with treatment planning of it. Particularly here, where we have a very robust valve clinic and patient population, a lot of what we do with this cardiac gating is to provide kind of precise measurements to allow for accurate sizing of a valve prosthesis. So we do a gated study through the whole heart, and then everybody's a little bit different in their size and shape and orientation of their valve annulus. So by freezing cardiac motion, we can get very precise measurements of the valve annulus here that can allow them to put in the appropriately sized prosthesis, because the complications of not having things sized correctly can be disastrous. I think when they first started doing valves, people looked at using echo for this, but when you're using an echo, you have a lot of variability from how the transducer is oriented. There's some, the technologist is involved, and there's some error inherent to that, and the plane may not be exactly right. So this allows a very accurate representation of the valve. Kind of along the same valve line is that mechanical prostheses, when they have problems, they're kind of they present a unique challenge for imaging. So metal is hard to image both by MRI and ultrasound because it's causing field distortion of the magnet or blocking sound waves. So we can do retrospective gating of a heart that has a valve and then watch the valve leaflet motion. And so if a leaflet is sticking or it's malpositioned, we can get a good look at that. This is kind of different based on clinical practice, but prior to doing like an electrophysiologic ablation for AFib, we do mapping of the pulmonary veins as they enter the left atrium. So we can define sort of the location and size of the pulmonary vein ostia, and then we can do reconstructions to look at the left atrial appendage. So if there's an atrial appendage exclusion procedure being done, kind of different techniques can be done based on the morphology and size of that. So aneurysm surveillance is another big thing. So like I showed earlier with the sort of duplication artifact of the aortic wall, you can't accurately follow an aneurysm with a conventional CT if it's involving the ascending aorta. So by gating the study, you're freezing the motion of the aortic root and ascending aorta, which allows you to give a very accurate size assessment. This is a patient here who had an aneurysm repair that dehisced and then formed a pseudoaneurysm. Here we can see, so this is the true ascending aorta. This is the pseudoaneurysm that has that's contrast opacified. It's actually sort of eroded into the PA, and there's the difference in contrast. You can see this fistulous communication that's forming. So this is for both surveillance and then sort of assessment of complication prior to surgical planning. So I wanted to shift gears a little bit and talk about some other applications and the evidence behind it. So calcium scoring is kind of a unique tool for cardiac imaging. What we do is we do a non-contrast gated CT through the chest, and then we use the computer to highlight areas where there's calcified plaque in the coronary arteries. There's a complex calculation the computer does that involves the sort of the number of pixels involved, the density of the pixels, and sort of the location of them, and it'll generate what's called an Agatston score, so a calcium score. And then you can compare the amount of calcified plaque that somebody has to large database, like the multi-ethnic study in atherosclerotic disease. And you can generate where they are percentile-wise. It's like the bad kind of childhood growth curve that you can see where somebody is. So that can provide some useful information for where people are in their plaque burden. So look at this. There was in 2015 there was a kind of a big study that followed these patients who had calcium scores for about 15 years. When the initial studies that came out on this, people had been followed for about 5 years, and they wanted to kind of assess like what prognostic value a negative calcium study was, or so if you had no calcified plaque in your coronary arteries, what that meant in terms of your mortality rate. So this is kind of the biggest study that followed people for a long time. So they got almost 10,000 people with calcium scoring, and they kind of broke them down to by their Framingham risk score, the ATP3 risk score, and then just other sort of historical markers of coronary artery disease. And they wanted to define what, if you have a negative study, so no calcified plaque, what that meant prognostically, and sort of they described it as a warranty period if your all-cause mortality is less than 1% per year. So the chart here is comparing, this is everybody in the study population. The Framingham and ATP curves are kind of the same, but the people who didn't have any calcified plaque in their coronary arteries, or a score of 0, had the lowest all-cause mortality rate. So they did some more breakdown to kind of compare what the mortality rate was kind of between them. So this is one of their slides from their paper, and one of the things kind of interesting. So it's a little bit busy to go through, but this side here is patients who have calcified plaque in their coronary arteries, and then broken down by their low, intermediate, or high Framingham risk score. So this is under 10%, 10 to 20, and then above that, above 20%. And these are people in the same breakdown, but with a calcium score of 0. And so, kind of an interesting thing. So if you had a high Framingham risk score, but no calcified plaque, you had the same mortality rate as somebody who had a low Framingham risk score, but had any plaque whatsoever. So then by kind of doing analysis of all these, they broke these down to kind of assign these warranty periods. So this, like I said, this is if you have an all-cause mortality of less than 1% per year. So look at this by Framingham score. If you have no calcified plaque, low and intermediate risk patients, they do really well, and that's regardless of age or gender. And same thing with the ATP criteria. So if you have a high risk, if you have a high Framingham risk and you have a low calcium score, you still have a 5-year warranty of not having anything happen. So one of my friends is a lipidologist at OHSU, and so he says that he uses these for patients who are intermediate risk and maybe are medication adverse, or maybe patients who are kind of reluctant to have medical therapy as a sort of risk stratification tool. So kind of like lung cancer screening and showing people that they have emphysema or they have nodules can lead to smoking cessation. If you show somebody that they have, they're at the 60th percentile plaque-wise for their age and gender, it can be sort of a useful tool for coaching patients to get them to do apply the medical therapy. Yeah, so I guess to kind of summarize, almost half of the people have no plaque or have no calcified plaque. So that information can be applied to a lot of the people who have the test. So just to summarize, calcium score is a 15-year warranty period. for low and intermediate risk patients. For high risk patients, about 5 years. Try to put a couple take-home points in this talk to kind of break up the imaging slides.
Do insurance pay for that?
So insurances don't pay for that. So the cost is relatively low. I think it's on the order of like, but it's out of pocket, but it's like $100 or $150 or something. The insurance companies may pay for that in the future if there's sort of increasing evidence about its prognostic value. Because if you can use that for risk stratification and potentially avoid medical therapy or direct care elsewhere, then I could see that being a valuable tool. But currently, no. Yeah?
Your slide shows very nicely the trajectory of estimated mortality based upon calcium score and other risk factors. This is also, I assume, age corrected?
No. So this is independent of age. So if you have a calcium score and you're 60, you have a 15-year, or if you have a calcium score of 0 and you're 70, same thing. Granted, if you're 70, you probably don't have this, but that was independent of age and.
And are there serial studies to show whether or not a person's calcium score changes?
Yes. So for this study, this is if your initial score is. But if your initial score is 0, even if it increases, you're still in that window of 15 years. Yeah.
Are the results just binary? I feel like I've seen results where there were different levels of the calcium score.
So they're not binary. So oftentimes what we report is this percentile. But I think the real value of the study is binary, is yes or no. So if you don't have any calcium score, or if you don't have any calcium in your plaque, which again makes up about half of the people in these populations.
We're really looking for those negative people.
Yeah.
And the positive makes you kind of hang.
Well, the positive it means that you don't. There's less value in that, but it can be a teaching tool for the patient. So if you're a 45-year-old person and you have calcified plaque and you don't want to take medications, and you're at the 60th percentile, it might be a wake-up call to do dietary or behavior modification. Yeah. Yeah.
Why is it that type 1 diabetes has high calcium?
So with diabetes, and you get intimal calcification sort of throughout the body. So it's more of a diffuse phenomenon. But we see that in diabetics like in. Yeah, but I think there's still, in my understanding of with type 1 diabetics, is that there's still sort of there's a field phenomenon for intimal calcification. So I think you get it elsewhere. Anyone else? The next part I want to talk about using CT coronary, doing CT coronary studies for evaluation of chest pain. It's kind of broken up into 2 different settings in which you would do this evaluation. Kind of big interest, initially we can talk about out of the ER setting. So anybody who's ever rotated through an ER knows that people come in with chest pain for a lot. So it's very helpful to have a risk stratification tool for that. So this is rule out MI by CAT scan trial. It's done at a single center where everybody involved was blinded to the results. So they took 368 patients who presented to the ER with more than 5 minutes of chest pain in the last 24 hours. So these are patients who they had a negative initial troponin, negative EKG, and they were going to be sent to observation for 20 hours for rule-out MI. And so what they did was on their way to the ops unit or the floor, or wherever they're going, they did a coronary CTA. And then they didn't use that to influence clinical judgment, but then they followed them up and compared them to what their outcomes were in their hospitalization, and then they followed them up for 6 months afterwards to see what the outcomes were. And so kind of interesting, there are 3 groups that they broke them down to in the paper, but about half of these people had no plaque in their coronary arteries. And so very high negative predictive value. None of those people had acute coronary syndrome. 6 months after, none of them had a major adverse coronary event. So for a big chunk of the patients, rather than potentially going through the traditional rule-out MI route, you could pretty early on say, you don't have this isn't the cause of your chest pain. These other groups, the water is a little bit muddier. So patients who have plaque but not significant stenosis, most of them did not have acute coronary syndrome, but 7 did. So if you want to have a good study where you can rule stuff out, I don't know that you can include these people. So the negative predictive value drops down a bit. One of the weaknesses of coronary CTA is that these positive patients, so these are patients who have a positive or inconclusive test, and they counted positive as if you had a left main stenosis of 50% or LAD, RCA, or circumflex of greater than 70% as being positive. So this is a smaller group, but with 68 patients, only 24 of them actually had acute coronary syndrome. So pretty poor positive predictive value. So I think the strength of calcium scoring and the strength of CTA are sort of parallel in that they both have very high negative predictive values and can exclude disease. Kind of the follow-up for this is the creatively named RAMICAT 2 trial. They looked at sort of applying this as a tool in clinical practice and how you could potentially change throughput through the ER. So this is a multi-center trial, and they took 1,000 patients, split them in half. Half of them they gave a CTA early on. And again, this is chest pain in the last 24 hours for more than 5 minutes, negative EKG, negative troponin. Half got CTAs, half just went through the standard care. And the key thing here is that half of them they were able to discharge right out of the ER, as opposed to only 12% of the standard care route. So the idea is that when you look at the sort of hospitalization stay, the time course of it is that their average length of stay is 9 hours compared to 27 hours. So the 28-day coronary event rate was the same for the patients who were discharged. And the cost, it's a little bit more for the CTA, but that wasn't statistically significant. So you're not saving cost yet by doing this because you're adding a new test that wasn't applied, but you're changing sort of timing efficiency and like personnel resources of a busy emergency department. So looking away from the ER setting and moving more towards an outpatient setting, there are a couple of big trials that have looked at how coronary CTA has affected management in those settings. So one of the biggest ones is this Scott Hart trial. So this is a 15 hospital multi-center trial out of the UK, funded by the NHS. So they took 2,000 patients, they took 4,000 patients, about 2,000 each group, and then divided them between the patients who had standard care, and then they added the CTA to their standard care. This paper looks at, there's a lot of sort of confidence scoring of the clinician standpoint. So they found that 6 weeks after they started the trial, physicians were more confident in a diagnosis of coronary artery disease in the patients who had CTA versus didn't. So one of the ways they reflected that was that at 6 weeks, 27% of people were given an alternative diagnosis as cause of their chest pain in the CTA group, compared to just 1% of the patients who went through the standard care. And then they followed these people for a long time. So they had some kind of interesting findings. So they initially reported these in 2015, but then sort of looked at the data again and presented some different things in 2016. So this is sort of a summary of both of them. But initially they thought that patients in the CTA group would be getting more invasive catheterization. So for the next couple slides, ICA is invasive coronary angiography. So initially they found that patients who got a CTA got more caths because you're finding more stuff, and that may or may not be helpful. But what they found is that over time, kind of the number of catheterizations ended up being the same. It's just they got them sooner in the CTA group, so the red line versus the standard, but then they get to be the same. But by doing them earlier, they found that people were treated sooner and given more more medical therapy earlier on in the group. And then the catheterizations that they did do were kind of more efficient use of time. So having a normal or negative cath is bad, and so you want to avoid that. And so only 20 of the 409 were normal in the CTA group, whereas more than double of that were normal in the standard group. And then the caths that they did, a higher number of them found obstructive plaque that was treated with intervention in the CTA group than the standard care group. And so, with those are significant. The end result, when they looked at sort of this is fatal and non-fatal MI after the kind of 6-week decision point was made, and so there were very low frequencies of MI. So I don't know how applicable this is, but in the CTA group there were 17 MIs versus 34. So it was these are very low frequencies to begin with, but there's a 50% relative risk in the CTA group. And they attributed this in the paper to sort of getting earlier treatment of disease. So to summarize a couple things, I really think the value of CTA is that it has a very high negative predictive value. In the ER, you can exclude ACS in about half of the patients and potentially result in getting them out of the ER faster. It doesn't save any costs currently, but it gets them through it sooner. In an outpatient setting, you can increase your diagnostic confidence in what's causing their chest pain. And then it leads to earlier catheterization, revascularization, and might cause reduction in MIs by providing earlier care. So it's sort of a better use of cardiac cath time. Moving on to kind of the new application of CT. So we talked about the high negative predictive value and that sort of prognostic fact, but we still have to deal with the relatively poor positive predictive value of CT coronary angiography. And so just as a little bit of background from the cath world, do we have any cardiologists here who can speak up if I'm misspeaking about this? But in cardiac catheterization, in the last decade or so, there's a relatively new technique called FFR. So rather than sort of historically where you catheterize a coronary artery, you inject contrast, and then you do a visual inspection of the lumen, what we do routinely now is you cross the stenosis with a micro wire, and then you measure the pressure before the stenosis and after the stenosis with vasodilation. So this is called the fractional flow reserve. So here's where the vasodilation is. You measure pressures before and after the stenosis, and the pressure ratio is a key thing because it's sort of more of a physiologic measure of the impact of a stenosis. And so it's not just, that looks like it's a tight space, but it's, actually the pressure of blood is causing there's a differential by the stenosis, and that's going to have a physiologic effect and not just a visual effect of the narrowing. So this is what they do in the cath lab. But typical coronary CTA is still not at this point. It's at the visual inspection saying, that area looks narrowing, and not knowing what the physiologic effect of it is. So what is done now, or what can be done now, and I think will probably be more prevalent in a couple of years, is this complex fluid dynamic modeling that will provide sort of virtual assessment of that. So what you can do, and there's one company that does this commercially and is FDA approved, but there are several other that are trying to do the same thing. You take a standard set of CT images from a coronary CTA. You don't have to do anything differently with the protocol, but they form this kind of complex model, a 3D model of the coronary vessels, and they do this, whatever this formula is. Involves a lot of this. But so you send the CTA data to them, and they they do these fluid models where they look at what flow does in an area of stenosis, and they are able to spit out some numbers. So it's a virtual FFR where by using computer modeling, they can predict whether a stenosis won't just look bad, but will actually have a physiologic effect. So I warned you about this. So this is a Bland-Altman plot. So this is a test of agreement between two tests. So there have been a few reviews on this. This is they took 5 articles that were doing this CT-FFR stuff, and they compared the CT-FFR to invasive cath FFR. I'm not a statistician, so when I look at this, here's how I think of it, is that in the cath lab, there are a couple different cutoff points, but low FFR numbers are bad. It means that there's not enough pressure in the distal coronary vessel. High ones means it's good. So you don't need to do anything with these areas, but these lower numbers would be where you would revascularize. So when I look at this, there's a clumping of the data points above 0.8. So in areas where you don't need to stent somebody here, there's good agreement. So an ideal version of this plot would be if everything was lined up on the 0 line. So looking at the diagnostic accuracy, so that's agreement between something being above 0.8 or below 0.8 is really high for the high end of the scale. And then even as you go lower, it's between the 0.8 and 0.9, there's good agreement between the CT-FFR data and the invasive cath FFR data. As you get below that, it gets pretty bad. But it doesn't really matter if it's less good down here. There's more variability because this is a wide range where you're going to revascularize them anyway. So another big test, or another big study where they looked at this in 2014, and this is one of the papers that made up the last review article. This group took 254 people who had a coronary CTA and a cath within I think 60 days of each other. And then they compared so they used the cath FFR as the gold standard, and then they compared the results of the coronary CTA, the visual inspection of the cath, and then the CT FFR. So the red is the CT FFR, blue is the conventional CT. So, kind of across the board, there's they maintain the high sensitivity and negative predictive value. But in kind of the areas of weakness of conventional CTA, there's a pretty big improvement. So the specificity jumps from 34 to 79%, and the accuracy goes way up. The positive predictive value, it's still not great, but we had 35 in the other paper and 40 here, but it's improved. So it's potentially useful information in guiding cardiac catheterizations and reducing them. Another way to look at that, this is whoever names these studies, they have a lot. This is the prospective longitudinal trial of FFR outcomes and resource impacts, which they summarize as a platform. So they wanted to look at if you applied CT-FFR to your cath lab patient selection, what you would do sort of efficiency-wise. So there are 2 parts of the study. They took almost 600 patients, broke them down, people who had chest pain, but they weren't planning on doing weren't planning on doing a cath. I'm not going to talk about this section for now. But they took 380 patients who were planned to have a coronary cath. They randomized them to, half went to the cath lab, and then half had a CTA with FFR. And so what they found was that by doing the CTA, they were able to cut out a huge chunk of their coronary caths. So it's sort of a busy slide here, but these red bars, this is where they, in the usual care route, where they did a cath and they found no obstructive disease. So it's a negative study that they didn't do anything with. So this is bad. It's sort of a waste of, it's putting patients through an invasive test that's expensive and expose them to radiation and potential complications of it for not really any benefit. They found kind of equal chunks of obstructive coronary artery disease that are treatable, but they were able to eliminate all these caths together and then reduce the negative caths from 73% to 12%. So I think by introducing CT-FFR, you can have a dramatic change in sort of cath lab efficiency and not do invasive testing on patients who don't need invasive testing. So go back to a summary here. With CT-FFR, I think that the evidence is going to bear out to show that there's kind of consistently improved accuracy and specificity compared to just a conventional CTA. The agreement is good to conventional cath FFR, particularly in areas where there's normal flow. So the value of that is really that you can reduce the number of invasive caths that don't show any treatable disease. All right, so that's it for CT. I was going to move on to MRI. Does anyone have any CT questions? Yeah. Yeah, so thank you for reminding me about that. I meant to talk about the calcium score. So yes, but less so. So recently, the big incidental finding thing is lung nodules. And I mean, that's for abdominal CTs for every aspect of radiology. And so for years, we would follow these benign nodules that never grew and never amounted to anything. And that was on the basis of a recommendation by the Fleischner Society. So there's a group of radiologists and pulmonologists who came up with these guidelines for it. They revised those in 2017, and the revision, as a chest radiologist, has been a dramatic change to practice. So the new guidelines, which that were released in January 2017, are much more permissive of incidental nodules that don't amount to anything. So the number of needless follow-ups have plummeted, basically. So all these kind of small little distals that before we used to comment on and cause patient anxiety, we just let go. And we still catch lung cancers, thymic masses, thyroid masses, adenopathy. So there are incidental findings, but a considerably higher proportion of them are useful, significant findings. I mean, I think just in the past 6 months, I've seen 2 lung cancers on a calcium screening. So yeah. Anybody else?
You may not have these numbers, and maybe one of our cardiologists does, but I'm just curious, nationally, what percentage of heart angiograms are done for stable coronary disease? Because theoretically,
We shouldn't be doing them, yeah. Yeah, that I don't know. And the like this slide, this reduction here is really dramatic. There was another study that is kind of redundant, but they took data from the PROMISE trial, and they did sort of after the fact analysis of CT-FFR. So the PROMISE trial was comparing anatomic CTA imaging to functional heart testing, and they didn't find as great a reduction, but it was still, I don't know it off the top of my head, it was still like a, I don't know, 40% reduction, a very significant number in reduction of the negative catheterization. Not 60%, but a huge number. So, and that was a big multi-center trial with thousands of patients in it. So I don't know the number off the top of my head, or what they are locally. Yeah.
Is it being used now, the FFR, in selecting who goes to angiogram, or is this still research type?
It's just out of the gate from being research. So nobody does this locally. I think they do this at Duke, they do this at Stanford, they do it at some bigger centers. But my expectation, so I was at a conference recently, and there's a lot of enthusiasm for this as being another tool. I think like I said, there are multiple vendors who are doing different modeling things and trying to make products that do this. So the fact that there's kind of competition by companies suggests that people are buying into it, or they're seeing that as a. Is there a question in the back? Yeah.
I was wondering if you could comment on relative radiation.
Yeah. So anytime we're doing additional radiation tests, radiology tests, we're exposing patients to radiation. So and it's not something that's insignificant or should be passed over. I think the radiation exposure is getting better. So when a lot of these studies were done, starting the coronary CTA studies started to come out in 2008, 2009. A lot of them were using 64-slice scanners and doing fully retrospective gating. So that's where they image throughout the whole cardiac cycle. Now more and more we're using higher detector numbers, and we're able to do prospective gating, so only for a portion of the cardiac cycle. So I don't have a chart to compare the radiation dosages, but you can get away with a reduction that's like a quarter of the radiation that it was a decade ago. So it's not ideal, but it's still, both of these tests are less radiation than coronary angiogram at the cath lab. They're better than a nuclear medicine stress test, but I don't have the exact numbers to compare to you or for you. Yeah. Not really. So because the chest CTs are not gated, but you can do, because like I said, the real value in calcium scoring is its negative predictive value. So you can get a rough sense of someone's plaque burden on that. So if you see calcified plaque on a standard chest CT, which we very frequently do, I try to comment it on every time because it moves patients out of that group of negative thing. But it's not, you can't quantify it in the way that you can with a standard calcium score study. All right. So let's move on, shift gears a little bit, talk about cardiac MRI. I've gone long with charts and graphs, so I'm going to go through this a little bit more quickly. Because this is a mixed group of different specialties, we're going to talk a little bit about the basics, kind of what we do. So for cardiac MRI, I think these are the best looking studies in radiology. They're just visually appealing to see the cardiac motion. What we do is we get sort of movie images in different planes that sort of parallel the existing echo planes, and then we can do a functional analysis. So blood is white, the myocardium is black. Flowing blood is supposed to be white, but when there's turbulent flow or regurgitation or mixing things, you get sort of macroscopic change to how the protons are aligned. You get loss of signal. So when you see regurgitation, it's black. But we're not limited in the way we are with echo by sort of imaging windows. So we can do stacks of images through the heart, and we can manipulate them kind of any way we want. So this is for doing functional assessment of the heart. This is our kind of workhorse sequence. So this is a short axis stack. This is the left ventricle. This is moving a little bit quickly than I liked it. This is the right ventricle here, and so you can watch the heartbeat throughout the study and sort of look for wall motion abnormalities. The other thing you can do is that once you have this stack of images, you can draw contours on the inner part of the heart, kind of around the outside, the right ventricle, and then you do that over all of the beating stacks that I just showed you. So from here is where you can get your functional information, so you can generate an accurate ejection fraction, myocardial mass, regurgitation fraction. You can do all of the typical functional analysis of the heart with cardiac MR. Another tool we have is something called phase contrast. So with phase contrast, you have an imaging plane that you set the cardiac MRI to sort of see how many water molecules are passing through something at a time. And so if you define a plane as the aortic root and the pulmonary artery, then you can generate curves of flow in those areas. And so if somebody has an intracardiac shunt, you can see a discrepancy there. If somebody has regurgitation, you can see negative flow. But it's another way to sort of quantify cardiac function here. Taking a step back and talking about echo, echo is a great test, and cardiac MRI is really complementary to it. So this is a kind of a rudimentary depiction of echo. So you have transthoracic echo, even a probe in a peristernal or subxiphoid or apical picture, but you can have a cone of usable images. So there are intrinsically some areas of the heart that are just not as well viewed by echo. So particularly kind of more anterior right heart structures, the right ventricle is tough to assess because you're limited by the sternum, ribs, lung that all block sound waves. And so for right ventricular analysis, cardiac MRI is really the gold standard of looking at things. So people who have like ARVD or arrhythmic right ventricle dysplasia, which is a diagnosis that's really dependent on size assessment, you really need a cardiac MRI to accurately do that. So this is how echo works for most people, but you run into problems where, if patients have a pectus deformity or if they have had prior surgery, where putting a probe on the skin to look at the heart might have more artifacts than otherwise. So this patient with partial absence of the pericardium and their cardiac axis is shifted to the side. You can imagine that if you want to do a functional assessment of this heart, that the standard echo planes just won't be available to that. So I think of cardiac MRI for functional analysis as being a troubleshooting tool in contrast to echo, because obviously it's longer, it's more expensive, patients have to sit still for a long time. So it's not something you can do on everybody, but it's something that can be helpful in select patients. The other aspect, rather than just the functional analysis, that the real strength of MRI is that we can do characterization of the tissue. One of the main ways we do that is with delayed enhancement. So we give contrast, we wait a while, and then we image. And after about 10 minutes, the contrast goes from being in the blood pool to the myocardium to then to the extracellular space. So normal myocardium is black. These are the kind of images I showed you before. And then when you give contrast, normal myocardium stays black. In areas of scarring or fibrosis, you get enhancement, so it gets abnormally white here. So we use this a lot for kind of characterization of the myocardial tissue. So there are a lot of different patterns of late gadolinium enhancement, and if you ever see a cardiac MRI report, this is sort of where we focus a lot of our attention. So the patterns of enhancement are significant. So this is a patient who had a large inferior wall infarct. So it's subendocardial involvement, and it involves the full thickness of the myocardium. This patient also with kind of an ischemic pattern, so the white area of the left ventricle is kind of restricted to the subendocardial region. Here we have a patient who has sarcoidosis, and there are patchy areas of enhancement in the mid-wall. This is a really not aesthetically pleasing image, but all of the myocardium is abnormal, so there's a diffuse pattern, and it's not just the left ventricle, but it's also the right ventricle. So this happens with sort of deposition processes. So this patient with amyloid, where there's kind of abnormal systemic deposition. In myocarditis, you can get a very typical mid-myocardial septal linear enhancement. So this does not involve the subendocardial region. So somebody who comes in with chest pain, this isn't an ischemic phenomenon, it's an inflammatory one. And then in patients with hypertrophic cardiomyopathy, not only is the LV myocardium thickened, but it also has patchy areas of enhancement that are used sort of prognostically for whether these patients should have a defibrillator put in or other things. For revascularization, the amount of late gadolinium enhancement with the myocardial thickness is critical. So this person had an infarct here, and it involves the full thickness of the myocardium. So you don't want to do a CABG or a PCI on a patient with full involvement of the myocardium because it's dead. It's just scar tissue that's not going to ever recover function. When there's so studies have shown that when there's less than half thickness involvement of the scar, you get functional improvement in the involved segments. So many times before a CABG, we'll do an assessment for myocardiability to make sure that we're not doing unnecessary surgeries on people. The other, with MRI, kind of like MRI elsewhere, the inherent tissue characteristics generate signals. So things that look like edema elsewhere in the body also it applies the same in the heart. So this sequence here there's a lot of white and fluid. So in a patient with myocarditis, you got edema in the inflamed myocardium, so we're able to see that on the MR. This is a patient who had a possible mass on an echo. we can see that this is all fat signal. It's identical to fat signal around the heart. So this is just lipomatous hypertrophy here, rather than a mass that needs to be removed. We see low signal with a clot. So this person had possibly an apical mass. We see this is a post-contrast image. So there's an apical infarct here, and then this, really clotted blood looks the same anywhere with MRI, but there's a low signal mass here that's a thrombus at the apex. So then, just talking a little bit about the sort of more advanced applications and not just functional analysis or tissue stuff is getting more into quantification of what the myocardial tissue is doing. So iron deposition in hemochromatosis, one of the things we do or are able to do and have been able to do for about a decade is watching so if you have iron deposition in the myocardium, irons will affect the MRI signal. I'm trying not to use too much MRI jargony stuff, but it changes the way the signal changes over time. So if we image the myocardium sequentially over time, the signal degrades or changes. And so we're able to plot out how that signal changes. And that's directly, the sort of the decay rate of this is directly related to how much iron is involved. So this is a patient with hemochromatosis. The liver has a lot of iron in it. We can quantify the amount of iron by MRI. And the myocardium has a lot of iron in it. So rather than doing a percutaneous biopsy of the liver or biopsy of the heart, we can say, this person has X amount of iron, which is, in this level of abnormal or not. So what has been popularized really in the last probably 5 years or so, and there's been a lot of research on this, and this I warned you about is the T1 reference, is something called T1 mapping. So the problems that we have with cardiac MRI is that when I showed you the images of the late gadolinium enhancement and the other tissue characters, it's subjective, and it's kind of dependent on an internal reference. So in areas where all of the myocardium is abnormal, it's tough to have a frame of reference to say what's normal and what's not. And the technical parameters of the scan, you can make something look completely normal if you don't have an internal control to it. So diffusely abnormal tissue and subjective tissue is a bit of a problem. And then for the late gadolinium enhancement images, people who have poor renal function, we just can't give contrast because of NSF. So ideally, we'd like to be able to do more tissue characterization in these people with a poor GFR. So a T1 mapping, this is a diffusely abnormal thing with a patient with amyloid. So a technology could, if they apply the MRI sequences wrong, they could make this look totally normal, which is a scary thing because there's not a reference to it. So T1 mapping is kind of a newer technique that a lot of people are interested in, but kind of similar to the iron deposition and decay stuff is that the amount of water that's in the tissue causes the MRI signal of the tissue to change at a different rate. So again, you're imaging sort of same areas over a different time, and you're able to plot these sort of signal decay curves. And then so rather than just looking at what the signal is, you're sort of also imaging how long it took the signal to get there. So you get what looks like a nuclear medicine study, which is not very visually pleasing, but you can see the average time that it takes for signal to change. And then you have a normal range of tissues, and then some diseases cause it to, this T1 signal to change more quickly, and other diseases cause it to go more slowly. So this is like Fabry's disease is a rare genetic disorder that's historically very difficult to delineate by conventional MRI stuff, but the decay of the T1 time is very, very fast in Fabry's and not in most other things. And then more and more research has been done in sort of what specific ranges of normal and abnormal decay times are. The other thing you can do is that, so this is all without contrast. So you can also assess for involvement of sarcoid, myocarditis, fibrosis without having to give contrast. If you do give contrast, you can do another thing called, you can calculate the extracellular volume. So the extracellular volume is like another marker of tissue remodeling. And this sort of allows you to do earlier prediction of abnormal tissue. So before it gets into a fibrotic phase, you can see the abnormal signal on these T1 maps and extracellular volume maps. So a lot of research is being done now and looking at whether this can provide prognostic for people who have have MIs and have surrounding at-risk tissue, and then also for, because this is quantifiable information, people who have like a cardiomyopathy who are being treated, you can track it over time and see if the impact is changing over time or getting better or worse. So with our new scanner that we're getting, we will be able to do this, which is kind of an exciting thing, because I think that for the next 10 years, this will become more of a standard part of the cardiac MRI. All right, so just a couple take-home points with cardiac MRI. The tissue mapping, it gives you quantifiable information. It's not, there's not the subjective bias, and you can track it over time. So there's repeatable numbers that you can say, this got better, this got worse. In patients who have renal impairment, it's not the same, but it gives you another way of looking at the same processes. So you can assess fibrosis and inflammation without having to give them contrast. And then future research is being done into sort of assessing at-risk tissues. So just to kind of summarize everything as we're wrapping up here, for you clinicians, if you want to look at the ascending aorta, and I can't stress enough, or really a lot of anterior mediastinal structures, order something as a gated study. We catch this almost all the time, but occasionally I'll see outside studies where doing cardiac gating would have been tremendously helpful for helping with a diagnosis. Calcium score of 0 is a very good thing to have. We all want that because it gives you a 15-year warranty. Coronary CTA are very good for having a high negative predictive value. And I think that if sort of applied into a workflow, you can improve the selection of patients for coronary cath and reduce the unnecessary caths. I think I'm excited about CT-FFR. I think that probably in the next 5 or 10 years, we'll be doing more of that. And then cardiac MRI, like I said, it's complementary to echo. We can do a lot of assessment of cardiomyopathies, looking for an underlying etiology. And then more and more stuff will be done on this quantitative techniques. All right. Thank you, everybody. I don't think anybody fell asleep. It was good.
Have just a couple minutes before 9 if there are questions. And then Dr. Whetstone.
So if we're admitting like an anesthetic rule out, if we order a coronary CT, will we get the calcium score and then that sort of risk stratification whether they should get in touch with cars to consider a cath or not? Like is that something that you could sort of roll out now?
Yeah. Oh, yeah. I mean, we do. So we always apply before doing a coronary CTA, we always do a calcium score to begin with. The reason for that is if the calcium score is over 1,000 or so, then the CTA is non-diagnostic. I mean, the risk is going to be very high to begin with, but you get a blooming artifact from areas of really dense calcified plaque that make it unreadable. So those studies go hand in hand. But the calcium score, it can also be done independently of that. And similarly, a coronary CTA, if you want, can be done independently. So if you're looking for anomalous vasculature or something else, we don't have to do a calcium score. It's just for people with chest pain, they're hand in hand.
The score was 0, would you not receive that?
No, because you can still have non-calcified plaque. And in that, the Ramicat trial, a lot of the patients who were in the middle section who had stenosis but not significant, a lot of those stenoses were non-calcified plaque. So.
And so if you have a 10% chance of missing it, and it was you, how much did you depend on a negative?
With the, for the kind of intermediate group? Yeah, that's where I think that if you have
Non-calcified plaque, when it looks fine, but it isn't fine because there's no calcium in it, and the question is, hey,
yeah.
I got something there that's at risk for me, can you be satisfied with 90%?
Well, that's really the outpatient setting. And so it's kind of a different population than the people who are in the in the ER who have acute chest pain. But if you're screening based on risk factors for coronary artery disease, yeah, I'd be very happy with a score of 0. But if I were in the ER with chest pain acutely, that's why we don't do those as inpatients. But if I was in the ER with chest pain and I had a coronary CTA that showed not just no calcified plaque, but also showed no non-calcified plaque, then I would be happy with. I mean, the Ramakat trial had none of those people had a coronary event after 6 months.
Well, we're right at 9 o'clock. Thanks for your attention, and feel free to come down for other questions.
Thanks, everybody.